keeping up the legacy of his father. Happy to have you with us today, uh, Dr. George.
Thank you, ma'am. Thank you.
Over to you for your presentation.
Thank you, madam. I hope you can see my screen properly
Yes,
and
it is
hear
clear.
me as well.
It
Yes.
is clear.
Uh, so I would like to thank the Pendelmana Society for having me, Kochu madam and Mumtaz ma'am, all for having me for this program, along with Kunjumuddin sir and Dr. Subhash as well. It's an honor to be here. So without much delay, I'll start with my topic, the art and science of laparoscopic port placement. I know the topic sounds very fancy. It was intentional, but what I'm going to speak is going to be very basic because there's nothing too fancy about this actually. It's usually a very basic thing, but very crucial when you start laparoscopy because this can make or break your surgery. So the from the beginning, you're getting your ergonomics right is very important. Having your OT set up properly, your table, your instruments laid out properly, your monitor placed in the right way. These are all things which can really make a big difference on a long run when you are doing multiple laparoscopic surgeries because it's not like the surgery is going to be over in about half an hour something. It may go up to 2 hours, 3 hours, depending upon the case. So getting your ergonomics right is very important, and port placement ergonomics is one such thing. So the principles of safe port placement is the first and most important part in laparoscopy is always visualization. I always tell our fellows and trainees, visualize first, see properly. We are using a 30-degree scope. Look from all angles. Make sure what you're seeing is the correct thing, or you're not mistaking something, or you're not missing an adhesion or something or the other in a surgery. So visualization is very important. Only then do you decide whether to cut or not to cut. So visualization is very important. So for that, your port placement is very, very, very important. And the next principle would be avoiding major blood vessels and major organs like the intestine or the bladder, things like that. And again, maintaining the right triangulation and ergonomics. Here, I will be talking only about contralateral placement of ports because that is what I follow. And technically, that is uh, better than the ipsilateral method. But again, this is up to the surgeon's comfort. So coming to the entry points, primary entry points, as you can see in this image, there are multiple entry points available. The traditional or the first technique that was usually followed is at the umbilical through the umbilicus. Again, this is something that you can always follow. This is what we follow as well when we are dealing with basic surgeries where the pelvis or the pelvic organ is not too large. So where you still have a good distance between the uterus or the ovary and the primary trocar. But if the pathology is bigger, in case of uterus with multiple fibroids, or if you're dealing with a large cyst, these are all things where if you put your scope, the at the level of umbilicus, what happens is you end up being very close to the pathology, and you may not get a panoramic view, and your view becomes very limited. So that is when you have to go higher. What we normally do is, according to the size of the pathology, we put the primary trocar about two or three or even four fingers above the umbilicus. So one such point is called as Li Huang point. Again, between the citiosternum and the umbilicus, you are not expecting any sort of adhesion unless she has had a midline incision for any laparotomy. Another entry point is Palmer's point. We normally use it for Varies entry. We don't normally put a trocar there, but again, in certain cases, you can even use a 5 mm trocar and a scope to have a primary view of the abdomen in case you're thinking of any adhesions or anything. And Jain point is something new that was developed by Dr. Nutan Jain. This is about 2.5 centimeter medial to the anterior suprailiac spine at the level of the umbilicus. So as you can see, there are various points where you can use for primary entry, but I would suggest stick to something. I mean, you don't have to explore all of these points. So what we follow is again umbilicus, or we just go about depending upon the size, or we have the Palmer's point. It's not like you need to use all of these points. Stick to one or 2 points and be an expert in that. So, like I said, entry site depends on the surgeon's comfort and preference, patient surgical history, that is very important, and the patient anatomy. If the patient is very obese, these are all things that can really affect where you place your trocars. So before you put your trocar, patient positioning is very important. As you can see in this image, this is how we normally place the patient in a dorsal lithotomy position with the legs on Allen stirrup.
അവരൊക്കെ എല്ലാവർക്കും ഇന്റർമീഡിയറ്റ് ന്യൂമാറ്റിക് കംപ്രഷൻ കൊടുക്കൂലേ?
Yes, ma'am. Normally, with the recommendation pragaram, you're supposed to give intermittent pneumatic compression throughout the surgery and until the patient is ambulatory. So we normally follow a scoring system called Caprini scoring. So based on the parameters that you can categorize the patient, and only very high risk patient requires low molecular weight heparin. Otherwise, all the other patient intermittent pneumatic compression until the patient is ambulatory is their recommendation. And the arms are tucked to the side. So what we do is the left arm is tucked on the side and the right arm is usually wrapped along the chest. So the anesthetists have a easy access to the IV line as well. And always, when you start, keep the table at the lowest position. Otherwise, you may have a lot of difficulty in putting the trocar itself. So keep the table at the lowest position, have a footstool so you can stand at a higher level. And we put shoulder braces as well, since we give a extreme Trendlin berth so that the patient doesn't slide much. So the entry technique, what we follow is either the Varies close technique or a visual entry technique, which I will discuss or explain further. We don't normally follow direct technique or a open Hassan direct technique. Again, I wouldn't say it's a safe technique, especially for beginners. Open Hassan technique, the problem is usually the incision ends up being too large and you will experience gas leak throughout the surgery. And such a problem during a difficult surgery is going to be a big headache. So primary entry is always done with the patient in a supine flat position. So what we use is a Varies. Normally what we use a 10 centimeter Varies. You can use a longer one in case you're dealing with a very obese patient. And before starting, before putting the Varies, always check the spring action and always the gas flow. What we do is we just push air with a syringe and see if it is patent. And always make sure it's fully screwed in as well. That's the only, if it's not screwed in properly, the safety mechanism won't work properly. And always remember to catheterize the bladder. And you can always put an nasogastric tube in select cases, especially while anesthetists, if they have put the ET tube incorrectly. And if there is a lot of air that has gone to the stomach, it is always good to put an nasogastric tube. Once when I operated outside, I've had a experience where the Varies went into the stomach, and after connecting the gas, we could hear gas coming out through the patient's mouth. So this is something that is very important that you have to keep in mind. And so now putting the Varies, we normally we put at umbilicus or at Palmer's point. We normally put a stab incision with a number 11 size blade, vertical. It's just a vertical, a stab incision. No need to make a bigger cut. Just a stab incision with the knife. Why do we use the intraumbilical entry? Basically, because that's the point where all layers of the abdominal wall they're all fused together, and it has a fixed peritoneum, and it is the thinnest point, and also because it's very cosmetic, you would not see the scar at all, and it's least vascular as well. So how you put your various So how you hold the Varies is important. How you have to hold is you can look at this picture. You hold it like a pen, and there are two ways of holding it. One is on the grip, as you can see in the first image, on the grip, and the second is on the cannula. This can be, you can hold on the cannula if you only have a very long Varies. But the patient is small and you have a long Varies, instead of holding at the grip, you can hold it lower so that the amount of varies that can go into the abdominal wall is lesser as a safety method. So place the varies vertically into the incision, and we normally measure about 4 fingers from that point below, hold the abdomen, and we lift it. So the idea is that you maintain this 90 degree of the varies on the abdominal wall. When you're lifting it like this and maintaining that 90 degree. It's not that you're going 45 degrees into the pelvis. You're maintaining that 90 degree with the abdominal wall, and you're pushing it in a single movement. And normally, technically, they say you will feel 2 clicks, but I would suggest don't try to feel for the clicks. Just insert in a single movement. And once it is inside, avoid moving the varies a lot. So the idea is that, see, even if you have gone into the bowel, it can just be withdrawn. You don't even have to suture the injury. But if you move the varies around and make that perforation of the hole in the intestine larger, then you'll have to suture it up. So once it is inside, use a 10 or 20 cc syringe, try to aspirate, see if you have gone into a vessel or the intestine, see for any fecal matter. If nothing is there, then you connect the gas. We normally don't do a water droplet test of any of such things. We connect the gas tubing and then switch on the insufflator and look at the pressure and the flow rate. If you're inside the pelvic cavity, your pressure will be less than 10 millimeters of mercury and flow rate will be more than 1 liter. Along with that, clinically assess as well, clinically assess the distension of the abdomen. The next, so if the umbilicus doesn't work, so normally if we fail to create pneumo at the umbilicus, maybe you try for 2 to 3 times, it doesn't work, then you go to Palmer's point. Or if the uterus is very large, it is up to the umbilicus or even larger, where varies, if we try to insert, it's going to go into the uterus or the cyst, which is large. That is when we go for Palmer's point. So it's a mid-clavicular line about 2 fingers below the subcostal margin. Again, you make a vertical stab incision. And here, instead of holding on the grip of the varies, you hold on the cannula always. And you place it perpendicularly into the incision. And then you push it. Here, you will definitely feel 3 clicks. And once inside, you follow the same method of aspirating and checking. And then you connect the gas tube and look for the pressure and the flow rate. So next comes the trocars. So first would be the primary trocar, 10 mm trocar. You can use a reusable metal trocar like what we normally use, or you can even use a disposable one, which has got serrations as well, which helps in retaining the trocar in that position and doesn't slip out that easily. So the importance of having a good adequate abdominal pressure before you put the primary trocar is depicted in this image. So according to RCOG and many of these guidelines, they say after you put the varies, the pressure should be kept at 25 millimeters of mercury. And once you have attained that pressure, and only then you go for the primary trocar entry. So because of this pressure, it creates a good safer space between the bowel and the abdominal wall. If you're dealing with a lower pressure, your instrument can easily go and hit the bowel or the aorta. So this case, I've already put varies at Palmer's here, if you have noticed, and I'm making an incision about 2 fingers above the umbilicus. So once that is done, I place it into that incision, and with my left hand, I hold it as close to it as possible. And again, I maintain the 90 degree with the abdominal wall, and I insert it. If you have to be very careful in this part that you have your index finger extended, so it acts as a guard. So you stop at that point where you hit your finger. So one thing that you have to keep in mind is the fact that if there are adhesions, bowel injury is very much possible in the case of in a close entry technique like what I just uh, uh, showed you. So here is where a visual entry technique is very useful. So this is a endotip. This is by Carl Stoves. This is a reusable trocar that can be used for visual entry. Or you can even get these disposable trocars as well. So the indication for usage of these trocars are if the patient has had previous open surgeries, cesarean, if she has severe endometriosis, or if you're expecting severe adhesions due to various reasons. This is when you use a visual entry technique. So this is a video of how we insert the trocar. So after the incision, just one thread I have placed it into the wound, and I'm placing the scope in the trocar. And then with the right hand, I'm holding the camera. The left hand, I am rotating the trocar. And if you look at the video on the right side, you can see how we go through different layers of the abdominal wall. As you're progressing, you can see the layers, and here you can see the entire length is almost gone in, and we are reaching the last layer here. That thin layer is the peritoneum, and as soon as we enter, there's a sudden gush of moisture, showing you that you're inside. And here, once you're inside, you inspect quite well, and you can see a large adhesion, a metal adhesion, right in front of the camera. So once the primary trocar is inside, what we do is we give a good Trendelenburg position so that all the bowel and all the upper abdomen organs, everything goes up and our pelvis is quite clear. Next come the insertion of the secondary ports. So this is very important. So here, unlike the primary port, you're doing it under vision. You're seeing through the camera. So our placement of the secondary trocars, I'll show you a picture soon. So here, one thing you have to be aware is that because again, you're doing it under vision, any sort of inadvertent injury can be considered as a negligence. So you have to be very careful here. The principles that you follow when you put the secondary trocars are it should always be inserted perpendicular to the abdominal wall. Avoid inferior epigastric vessel. You can see in the image how it is just lateral to the obliterated umbilical artery. Two ways of injuring epigastric vessel is if you put your lateral trocars very medial, or if you have put the incision on the abdominal wall correctly, but seeing a bowel or something, you have lowered the trocar and you have inserted. So what happens is the entry point at the level of the skin is normal, but your exit point inside the pelvic cavity will end up being very close to the inferior epigastric vessel, very close, very medial as well. So another thing what you have to keep in mind is to avoid bowel or vascular injury and always minimize hernia risk. Again, one picture showing the inferior epigastric artery is just lateral to the obliterated umbilical artery. So one of the most common causes of stressful surgery is always wrong placement, wrong port placement. Like I said, this can break or make your surgery if, like we've had situations where our trainees have put the trocar and it is either oblique or it is put too high or put too low. This can completely make your entire surgery very difficult. So always plan and take your time in placing the port. So this is our routine port placement. So the white circle shows the primary trocar where we put the scope. So if it's a normal size uterus, if it's a small uterus, we normally put the primary trocar at the level of umbilicus. The lateral trocars, these are put about 1.5 to 2 finger above and medial from the anterior superior iliac spine. And the middle trocar is usually about 3 fingers above the pubis. But if you're dealing with large pathology, large uterus, large myomas, large cyst, you always have to make your trocars go high. It is not just the primary trocar. Along with that, the lateral and the middle trocars also goes higher. So this is very important. So one advantage with the lateral or the secondary trocar is that you are visualizing and doing it. So you can see the pathology. So if you're dealing with a large uterus, your lateral trocars should correspond with the same level or the fundus of the uterus at least. If it is too low, what happens is your instruments will be going in the direction of the head, in a cephalic direction. You should be approaching from the side or it should be going towards the pelvis. So you have to go higher as it is required. The whole design or the diamond placement of the ports is based on this baseball pitch. So basically you can see you have the primary the port here, 2 lateral ports, and you can have the middle port here towards the target of dissection. So I'll be done in about few more slides. So this is the basic principle on port placement. When you are putting uh, the trocar, this point, the point of the skin, the abdominal wall, and acts like the fulcrum here. So you should have an equal length of the instrument outside and inside. So that means it equates to a equal amount of effort and load that you apply. But if you end up putting the ports very close, that means it's not high enough. It's very close to the target tissue. What happens is the maximum length of the instrument is outside. So here what happens is, so you can see the fulcrum is closer to the load, to the tissue. So what happens is any sort of force that you apply, it gets magnified towards a tissue area, and that can cause inadvertent injury to the organs here. And along with that, because you're very close to the pathology, so imagine there's a uterus and your trocar is right here, your elevation angle is very steep. So it becomes very difficult for you to manipulate the tissue. On the other hand, if you put the trocar very high, what happens is any sort of small movements that you're doing at your hand end gets magnified, or the movement is it becomes magnified. If you're just moving 2 centimeters here, the tip of the instrument will move about 4 to 5 centimeters on the other end. And here the elevation angle becomes very less. The handle of the instrument could even touch the body. Or sometimes what happens, like imagine how you try to pick a mango or a fruit from a tree with a very long stick. That's a sort of that's the way you'll be struggling when you're dealing, if you put your trocar very high during the surgery. And second principle of the port placement is about the telescope. So telescope should be in the middle of the working instrument. You have two lateral trocars, and then you have the scope in between. So the angle between the lateral trocars and the primary port should be about 30 degrees. So you have enough triangulation. The third principle is the manipulation angle. The two lateral trocars, the angle between them should be 60. So that means angle between the two lateral instruments is 60. Angle between the scope and each instrument should be 30 each. And elevation angle should be about 60 degrees. Elevation angle is about that angle from the point where you put the trocar and the tissue downwards. You can probably understand it in this image here. So this is the elevation angle. So if it is too less or too much, can cause difficulty. So 30 degrees of azimuth angle is ideal, 60 degrees of manipulation angle, and 60 degrees of elevation angle. So these are the basic principles that you have to follow. So I'm almost done with my presentation. So here you can see what I do is I look at the screen, I'll probe with my finger and identify the area where I have to insert the trocar. And then I make a incision there. And then with my right hand, again, I'm looking at the screen. Always look at the screen and never at the abdomen. And again, you would have seen how I've changed the angle. That is only when you have already, the tip has entered the pelvic cavity. Otherwise, still the tip enters the pelvic cavity, maintain at 90 degree. Once you have entered the cavity, then to avoid a large like your intestine or the uterus or something, you can always change the direction and then enter. But don't change the angle before that. What happens is that you will go very oblique through the abdominal wall, and then especially in patients like this, obese patients, you'll find it very difficult to manipulate the uterus. So here I'm putting the middle port. You can see I'm pressing with my finger and identifying where to put, identifying the upper border of the bladder as well before I go ahead with the insertion of my the middle trocar as well. So these are basically the simple principles that you have to follow. There is no huge science or big complicated science when it comes to port placement. Remember the basics, follow the basic, and try to keep it simple. As I mentioned, try to master one or two techniques that can be used in almost all the different scenarios. You don't have to master every different technique that you see on the internet or when you see some publication. A lot of times there are a lot of points of entry which is sort of unnecessary, but keep it simple. And one thing to always keep in mind, if you're trying a new technique, do it on a simple case. Never try a new technique on a difficult case for the first time. So with that, I'm concluding my talk. Thank you for giving me this opportunity to Pentalmana Society of OG. Thank you.
Thank you, Dr. George, for that very elegant and very crystal clear talk. And as you summarized, it is like you kept it very simple and very clear.
Yes, ma'am.
Thanks a lot. And hoping to have you with us again in future.
Definitely.
If there are any doubts, please unmute yourself and ask among the audience. If anybody want to ask Dr. George anything, please unmute yourself and ask. I don't think because it is very clear.
It's quite a simple.
Yeah. Thank you.
George, I just want to ask, or
Yes.
you can just brief regarding the entry in Palmer's Point for the delegates who are attending. How to put a trocar in the Palmer's Point?
So we normally put only our varies through the Palmer's Point, and the indication is usually when the pathology is very large. If the uterus is very large, where you can't put a varies at the level of umbilicus, is when we go to Palmer's. So Palmer's, how you can identify is from the mid clavicular point, you go down about 2 fingers below the subcostal margin. That portion is where you put the incision. Again, before doing this, it's always better to put an nasogastric tube in case the stomach is inflated because of gas entry or something. So always put a nasogastric tube, deflate it, and then only make this incision. And again, varies, you hold it on the shaft, and then in a single go, you push it in. Again, this is for varies entry. As you mentioned, a trocar can also be placed as a primary trocar as well. So here, just like your varies, you'll be using a trocar. You hold the abdominal wall, and then same way, you go perpendicular into that space. And once that is, usually put a 5 mm scope, and you can have a primary view if you are expecting any sort of adhesion at the level of umbilicus or above. That is when you put a primary 5 mm trocar at Palmer's. I hope
Thank you.
that suffices the explanation.
Thank you.
Thank you,
And
ma'am.
as he correctly said, when you want to try this new thing, not on a difficult patient.
Definitely not. Definitely not.
Okay. So I think we shall move on to the next speaker, Dr. Subhash. Thank you, George, again.
Thank you,
Thank
ma'am.
you.
Thank you for having me. Thank you.
Dr. Subhash.
Madam, good evening, madam.
Good evening, Subhash. So you are finally on a seat, sitting. Because you're always flying around. Whenever I call you, you are in the train or you are in the flight or you are operating always. So I don't think anybody needs an introduction, but to be formal, please share your CV slide.
Madam, just give me 1 second, madam.
Oh,
There
sure.
is a small
It,
Georgia Pole.
it is not as easy as your surgeries, right?
Georgia Pole.
No, I'm here. I'm here.
He is my Zoom teacher. He is my got it. Kitty.
Okay.
He is my teacher because I am not used to many things as tech savvy as he is. Well, I think these are my credentials, and I think I would like to thank the President Kochus Mani, Madam Secretary Mumtaz Madam for this wonderful opportunity. Again, I would like to thank Kunjumudin sir for this wonderful opportunity again of starting this society called as Perindalmana Society. Though it sometimes hurts that Perindalmana Society is formed from Calicut Society, it has been a wonderful thing to see that, with so many members, of at Perindalmanna. It's almost about 150 members. I think it is imperative that, we had a society in Perindalmanna where a lot of people couldn't come down to Calicut. It's not easy for them to come down. Only thing many times you would see was Mumtaz madam driving all the way from Perindalmanna for IMS or Cogs meeting. So it is very nice and it's a very wonderful. And congratulations to Perindalmanna Society for the wonderful work. And again, congratulations for the.
Others, please mute. I think, is it Bina madam?
The
Yeah.
admin probably
Can you
mute.
please mute others?
Right.
Okay.
And,
Okay.
and again, very happy for Perindalmanna Society that they have actually had their own building, their own, a very, very solid bank account. So it's not easy for a society with almost 4 or 5 years to have such a good things. And congratulations to the whole team of Perindalmanna led by Dr. Gunnimaidin, the founder president, and the other presidents for taking it over. Now, the topic that's been given to me today by my.
Before that, Subhash, 1 second, your CV screen. Yeah. So he is our own KFOG secretary. That is the first thing I want to tell about him. Anytime you call him for anything, he is always there. Though he may not be free always, but he will definitely call you back. Yes. And he's also the chairperson of Foxy Endoscopy Committee and also the Medical Legal Committee. And he's a consultant endoscopic surgeon operating all across India. I think that is enough. Subhash, please carry on.
Thank you, ma'am. Thanks a lot, ma'am. Thanks a lot. Again, at the outset, I would again like to inform everybody that we have this project called as Project Eagle, where the meaning of that eagle is every aspiring gynecologist should learn endoscopy. That's the whole idea about this, and we have planned about 500 programs all over the country. Already about 15 of these programs have been held in the last 17 programs have been held in the last 20 days, and it's going wonderfully well. Dr. George is actually traveling all the way to Pushpagiri, Tiruvalla on 22nd for a workshop. Dr. Rajesh and Tasneem had been to Dindigal about a couple of days back. Again, we have a lot of programs being planned at KMCT, at Malabar Medical College, at Kottayam Medical College, and also at I think wherever George പറഞ്ഞത് നമ്മൾ തൃശ്ശൂരും ഉണ്ടെന്ന് തോന്നുന്നു തൃശ്ശൂരും പറഞ്ഞിട്ടുണ്ടായിരുന്നു തോന്നുന്നു. So basically, the idea of this whole thing is not to teach about laparoscopy, but to have an interest for many postgraduates towards endoscopy. Of course, in Kerala, it is not a problem because most of the medical colleges do have endoscopy units, so it's not a difficult task. But once you leave this place, once you leave this state of ours, the great state of ours, it's so difficult for the students to be even exposed to basic endoscopy. So the idea is to sensitize the children or the postgraduates to an endoscopy more. So, many times when you go to teach the students, it's basically the associate professors and the assistant professors who are actually more inclined to learn than the younger ones. So that's the whole idea about it. And I would like to thank all the members of the Kerala Endoscopy Group who actually volunteered, because this is actually a voluntary program where you're not paid for anything. It is your own interest and the interest to teach postgraduates that actually lures all these seniors, all these senior pros like George, Tasneem, Rajesh, myself, all of us know we keep going to this very often. Now, coming to the topic per se is ovarian torsion. Now, ovarian torsion, as we all know, is a very rare but an emergency condition in women. And always, early diagnosis is necessary to preserve the function of the ovaries and tubes and prevent severe morbidity. Unfortunately, to us, most of the times, by the time these patients do come down to us, they are already in such very bad stage. They're in really, really, really bad stage, in the sense that, almost all of necrosis occurred and the late diagnosis. Every time I keep saying this, it's always a late diagnosis. I don't blame the radiologist, I don't blame the clinician. I would always blame most of the times to the patient themselves, who would always feel that, you had pain for 2 days. വേദന ഉണ്ടായി 2 ദിവസം നല്ല വേദന ഉണ്ടായിരുന്നു പക്ഷെ ഇപ്പൊ വേദനയില്ല. So that is one of the most wrong thing to do. Patients, what they do is they would say that they don't have pain. They had pain, severe pain for 2 days. They've taken on analgesics, but now there is no pain. And that is one of the most common reasons that they don't come down to the hospital, only to find everything has been undergoing necrosis or ischemia in about 4 to 5, 7 6 days time. Now, ovarian torsion refers to the complete or partial torsion of the adnexus supporting organ with the ischemia. If it's a partial torsion, please to remember the clinical symptoms. Please to remember that the patient is actually going to give you a history of pain on and off. The moment they would say that there's a pain on and off, then that would mean that that this patient must have had some sort of torsion. But what is more important or characteristics feature about this is Please understand the ovary is a very small organ, about 2.5 or 3 centimeters size, and the tubes, the tubes and the ovarian ligament. The ovarian ligament is a very small, a ligament over there. So what happens when you have a size of an ovarian cyst about 5 centimeters, 6 centimeters, 7 centimeters, more so when they are filled with fluid, in a sense that it is not endometriotic, it is a matter of a serous fluid. It may be a simple fluid. It could be a huge para-ovarian cyst, or even for that matter, dermoid cyst. Now, these are the ones which are more prone for torsion. There are many theories which have been put forward for torsion, starting from your pulsations, starting from your long round ligament, your long ovarian ligament, long infundibulous pelvic ligament, movement of the abdomen. All these, you can, a lot of theoretical aspects which can be spoken. But please to remember that when an ovarian cyst comes down to you about 5.5, 6 centimeters, do always think in your mind that this could undergo a torsion. I am not giving an excuse to remove every ovarian cyst that comes out over here. No, I'm not here to say that. I'm only giving you that. Please suggest, the ladies when they have this sort of an cyst, that do keep in mind. And the chance of having a torsion in most of these cases is about 99% no torsion. It's only 1% that these patients are going to have torsion. So it's not that you have to scare the patients that you're going to have a torsion, but do keep in mind. 2% to 15% of patients who have surgical treatment of adnexal masses. And the main risk of an ovarian torsion is an ovarian mass itself. Now, please understand, this is a very important triad that we have. Acute onset of pelvic pain, nausea, vomiting, and an syncopal attack. The moment the patient would give you a history that I've had a pain and suddenly I've had some and some sort of nausea. Vomiting may or may not be there. But when you have this, there is no doubt in your mind that you have to think, and if you find an ovarian mass on an ultrasound, you have to think in terms of an ovarian torsion. I am not speaking theory again and again. I'm giving you the practical aspects because this is what we normally, as a tertiary care surgeon, when moment it comes, many of them these cases are referred. The moment they come down to us, we always unfortunately see this section. Please understand that the ovary has a dual supply, a dual blood supply, both from the ovarian artery and the uterine arteries. So that is why your diagnosis is always delayed because of the dual blood supply. Whereas if you have something on the fallopian tube, then that has only one, the Samson's artery, and that would actually be causing a lot of pain. So your diagnosis of an isolated torsion of the tubes is very early, but an ovary is always late. Now, twisting of these ligaments can cause venous congestion, edema, compression, and eventually the the loss of blood supply to the ovary. All this happens in this particular way that I've said. First is the venous congestion, then comes the edema, then the compression of the arteries, and eventually the loss of blood supply. Please understand, the compression of the artery is the last thing to happen in any patient, which means that there will be a lot of pain and the patient will have pain, 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 pain. But as I told you, in 24 hours or 48 hours of time, if the patient says, I have no pain now, that is a bad sign, which means that it has gone in for necrosis. There is no more blood supply to the head, and hence there is a loss of pain for this patient. Now, constellation of these symptoms, including severe pain when blood supply is compromised, is the clinching factor. Okay. Now, true surgical emergency is one that can lead to necrosis, loss of ovary, and fertility aspect if not identified promptly. Now, you have a 16-year-old girl who has come to pain abdomen institute, but the best part about this lady was she was not responding to medication. I would say the best part because that is what actually prompts you to do an ultrasound. Okay. And definitely, what next? Ultrasound. I think we are all doing our own sonologists. Most of our own gynecologists do their own sonography. So what you do is you do an ultrasound Doppler. Now, when you do this, you find a 7 centimeter left paravenous torsion. What next? Counsel and management. When you counsel these patients, when you find for a torsion, always take a consent for, your removal of that organ. It could be adnexectomy is a very safe option. Don't write laparoscopy and proceed. Don't let laparoscopic ovarian cystectomy bar the thing. Don't write lap salving because you never know what is in store for us. And usually when the ovary torses, it doesn't torse alone, it takes the tube also with it. ഞാൻ ചത്താലും കുഴപ്പമില്ല നിന്നെ കൊണ്ടേ പോവുള്ളൂ. So it will always take the tube also with that. Hence, for this reason, when you take the safest option is lap adnexectomy bar conservative surgery is your consent part of it. Okay. Now, please understand Doppler ultrasound is the best to determine the blood flow to the ovary. Now, the classical whirlpool sign, the round one of the ovarian vascular pedicle may be present, but it is not pathognomic of a torsion. If you don't find a whirlpool sign, that doesn't mean that the patient doesn't have a torsion. Okay. venous blood flow. Please understand, it's the venous blood flow which flows, which disappears first, and then the arterial.
Machine on ചെയ്തു.
And that is the reason why I have been stressing on the fact that when there's no pain, that is a dangerous one. Please understand that evidence of blood flow, especially if the blood flow is present in the interior of the ovary, does not exclude torsion. By our definition, we have said that when there's a loss of blood supply, you'll have torsion. But if you find a blood flow, that doesn't mean that there is no torsion. Please understand. Please do understand about this. Okay, right. Now this is a reason over here. I'm going very slow over here. Now, there are certain things which I would like to share upon with you. Now, this is one of the cysts over here. You can see there is a white ovary. When you see this particular picture, you're very, very comfortable, very, very happy because, yes, you are in a good position to save this ovary because you don't have to remove the ovary. But first thing is you inspect. And the moment you inspect, you can see here, this has actually undergone 3.5 torsions, And what is good to see here is there is a small cyst over here. Now, this is basically a paratubal cyst. That's one good thing, And you can see the blood supply. You can just see the blood supply initially. It is, can you see this is dark one? This is dark over here. Please do this. And just see here. The moment you detorse, you can see this. Can you see this? The moment the torsion is gone, can you see the blood supply? The blood supply is coming back. It is becoming more pinkish and pinkish, which means that we need not. You can see the bladder was full, so hence we were actually draining the bladder. You can see over here, simple, just put a little bit of current over here, just very little bit of current over here. Even if you don't put with a Caesar also, it's fine. With a monopolar, it is fine. With a harmonic, it's fine. Anything is fine. All you need to do is just give a small cut over here. Okay, or just give a cut over here. So you can see here, just give a small cut. This is the bipolar dissector over here. George, how do I? Yeah, okay. Okay, simple.
തിരക്ക് പിടിക്കൊന്നും വേണ്ട. ആ സൂര്യ സർജിക്കൽസിൽ പകല്
ഫാസ്റ്റ് അടിക്കാൻ പറ്റുന്നില്ലേ?
സോറി, ഫാസ്റ്റ് ചെയ്യാൻ അത് കാണുന്നില്ല, അതുകൊണ്ടാ ഇവിടെ കാണുന്നത്. സഡനായിട്ട് കണ്ടപ്പോൾ കാണുന്നില്ല. So you can see here, just very simple lifting it up, just a little bit of traction and counter traction over here. And there's a small edge over here. Can you see there's a small edge over here which you just need to cut across. Okay, that's good enough. I'm going very slow because it's very, very, very simple. Just traction and counter traction. There is an area over here. Just take it across. Just give a cut over here. Okay, that's it. Very simple thing. Just take across the fluid over here. But always and always inspect the other side. Okay, always and always inspect the other side. You can see over here, all this is good enough. There's not much of blood flow here. There's not much of a problem. Just leave it across. You don't have to worry much about this. Okay, this is what we normally do, and that's how you may find some amount of bleeding here sometimes. We may just have to do a bipolar over here, just a little bit of here. But again, if not, you can always follow Paul or Paul's technique where you just pinch both the ends, keep it for about 2 to 3 minutes, and the bleeding would stop. Okay. Now, determine the viability of a tossed ovary during surgery is by gross visual inspection. You have to have a good idea about it. Now, dark and enlarged ovaries may still have vascular and lymphatic congestion and may seem non-viable. But that doesn't give you an idea that please do remove the ovary. No, it doesn't mean that. Try to retain the ovary, even if it's black or brown, but take a consent. Tell the patient and their relatives that you may require a second surgery if things go wrong. Most of the time, these are all younger girls. When they are younger girls, you always tell the parents that, see, I will try my level best to retain the ovaries, to save the ovaries. But tomorrow, if things go wrong and you may need a second surgery, don't pounce upon me. Take everything on consent and give them. 99.9% of all these parents are willing to take a risk because it's a matter of the girl's fertility aspect. Okay. Now, similar one over here, there we have actually done the conservative sort of surgery. Now, please here, it's a different thing over here. You can see over here. Now, this is black, dark, very, very dark one. Similar one over here. Can you see this? Yes, you can see over here. There's a very, very dark one. You can see this. This is actually, we never thought what it was. When we turned, we turned down to be a, you can see here. Can you see this? 3 or 4 columns of torsion over here. This is basically an isolated hydrosalpinx, the torsion of the hydrosalpinx over here. Okay, can you see this? Okay, I can see over here. Now, when you hold this, you can see it's an area which is a necrosed one. But please understand there's a basic difference between isolation, the torsion of the tube and our torsion of the ovary. When it's an torsion of the tube, we don't have much of an option because it's actually gone into gangrene. It's gone into it's all friable tissue. The moment you take it across, it's actually coming out. Now, in such a scenario, what we normally do is we actually try to take it across. There is no option in doing for a conservative one over here. Unfortunately, you can see over I have just put it. But what you can see is this was actually a simple, like a lot of fluid over here. Had this been diagnosed early, probably then this would have actually been helpful where we need not have actually removed this early. You can see this is actually a simple cyst over here, which could have actually been saved actually. Okay. Now this is what. Now left ovarian torsion, now again over here. But please understand, the moment you have had a torsion in one ovary, we can always think in terms of saving this ovary. Now what we do is, you can see over here, you take a stitch under the round ligament. Okay, not over the round ligament, but other part is very, very important. You take a stitch from below the tubes. If you take a stitch from above the tubes, it is as good as you doing an iatrogenic self-ingectomy over there. Okay, or now again over here. Okay, you can see over here, you take it through this, you can take it through this, you can take it through this, and then you actually shorten. You can shorten the ovarian ligament, you can shorten the round ligament. Now these are the techniques which you can do. In patients, when you've had a torsion over here, always remember when you had one side, you can always do a prophylactic on the other side also. But that depends on your clinical condition. That depends on when, if you find that the length is more, then you may be justified. But otherwise, just because you've had one torsion on one side, I would not actually prefer that you would actually do it on the other side again for all the cases. So I'm not here to say that do this for every case. Okay, and you can see they leave the cyst part over here that will actually take the size, the shape of the ovary in future for sure. Okay, now you can see here we cannot do anything to manipulate because most of these are adolescent girls. But it's more of the adolescent girl, you cannot put a manipulator and lift up the uterus. That is why you're struggling with only two ports over here. Okay, you can always put a third port or a fourth port. That's okay, not an issue at all. Now, in such cases, this is what I showed you now was a hot dog in bun technique, when you can also plicate the posterior ovarian fossa, which actually will help you to decrease the ovarian ligament. You can also do application of the ovarian ligament also along with this. Of course, bilateral ovariopexy, I've put a question mark because it is not something which is advised. But if you find that this patient is more prone for that, or probably you are scared, you don't want to take a risk, of course, bilateral ovariopexy is something which you can always go ahead and do it. Okay. Now you can see over the other case again with the torsion over here. Okay. Now this case was actually done with laparotomy. Now the topic of the day is laparoscopy, but what I'm trying to convey is it is not very sure that you have to do a laparoscopy always. If you're not comfortable with laparoscopy is also good enough. But you can see over here on the left side, it is actually very much torse. When you detort it over here, you can see the color is actually coming back. Can you see this? What is dark? Once you detort, wait for about 10 to 12 minutes. I'm sure a lot of seniors here will also agree with me that they've had a lot of experience. Seniors have had a lot of experience. They would have already said, you wait for some time and definitely it will actually come back over here. Now, in certain situations like this, you can do something like this. You can see over here, this is actually a torsed one over here. But this is not my video. I have just found it out. It's very, very strange happened in this video is you're giving punctures over, trying to remove all the edematous thing over, and you're plicating it. Can you see this? You can plicating this part of the ovarian ligament and then actually making it across into this. Now, whether you leave behind such a big ovary which is actually underwent torsion with a lot more necrosis, that again, as I said, you have to take a consent for the same. You take a consent for the same, you tell the patient relative that you can going to do that, and of course you can do. Again, you can over here, can you see this? This is actually you're taking a bit through the infundibular pelvic ligament and actually fixing it up. This is, and you can see the tube. Can you see the tube over here? Please understand the tube over here. The tube over here is also actually very edematous. Don't go ahead, do not remove the tubes, leave it across. It's actually inflammatory one. Wait for about 6 weeks and then again come back to normalcy. Again over here, can you see this? You're shortening the ovarian ligament over here. Okay. Okay. Be careful with the needle. The needle direction of the needle is wrong actually. Okay. Now that's what you do so that this is called as almost as good as a bilateral ovariopexy over here. Okay. Now this is something which is very, very different. You can see over here that I found out that there's an ovarian cyst. I found that this may undergo a torsion. I've gone for something else. But what I did is I actually went out and did a prophylactic cystectomy over here. Now, this is just a picture again to show you that when you're removing a cyst, if you find that probably you are not very sure about the diagnosis, you're very tensed about it. It could be a borderline malignancy or a borderline epithelial tumor. In such a case, put it in a tube, remove it in a bag, endo bag, take it out in a bag, give it for frozen. In case if the report comes something which is abnormal, go ahead and do what is required. Or else you don't have to worry much about it. Okay, this is something which actually I would really suggest. But as much as possible, try to do these cases under laparoscopy because these are all young girls. You do not want to have them, a big young age. You have a torsion. Please think in terms of ovarian pregnancy also. It's a very, very rare thing. Very, very rare thing. You may have, it would look like a corpus luteum cyst rupture and you have pain abdomen. But think in terms of course, ectopic is one, but ovarian pregnancy is also something which you have to always think in terms of it. In the Spielberg criteria, long before it was criteria done long before even my grandfather was born, was a very old one. But please understand, the classical management of an ovarian pregnancy is always surgical. But what surgical? If it's a very small ovarian pregnancy, less than half of it, you can do a partial ovariotomy. Okay, ovarian wedge also. But for a larger lesion, you do an ovariectomy or removal of the ovary because it's going to bleed like anything. So do think in terms of ovarian pregnancy and ectopic also in such cases, the normal ectopic also, not the ovarian ectopic. Okay. Now, lap or left side, anything is fine with do. Okay. Now, thank you very much. To be old and wise, you must always be young and stupid. This is what I keep saying very often, that you learn from what the seniors have always taught you across. Okay. Right. Thank you very much.
Hi,
I think I'll stop the sharing.
thank you so much, Subhash. Am I
Madam?
audible? Ah, yes.
Yeah, audible, ma'am.
Yes.
Yes.
Yeah. Thank you so much for those very, very, very beautiful videos. Thoroughly enjoyed it. Thank you so much for
Thank you, ma'am. Thank you.
making it look very simple, but we know how difficult it is when you perform.
No, ma'am. It's
Especially
easy to
that perhaps ovarian cyst is the most difficult thing where you don't want it to rupture and you have to peel it off like very gently and all that. But
ma'am.
your videos were very, very superb. Thank you so much.
Thank you, ma'am. Thank you very much, ma'am.
So please, somebody, Cam, you want to comment something? Anybody want to ask any doubt to Subhash?
Yeah, Subhash, that was really wonderful talk and wonderful presentation and videos as usual.
Thank you, sir.
So would you like to comment? There is some unnecessary push. I don't know whether it is necessary or unnecessary push on against I'm just a little bit out of the context because there in the differential diagnosis very often this ruptured endometriotic cyst and ovarian torsion sometimes confuses with regard to the clinical findings. But there are some recommendations or pushing towards not to remove the endometriotic cyst rather than coagulate with laser. What is your take on that?
Sir, I belong to the very old school, not even old school of thought, the very old school of thought, sir, where I still believe the good old cystectomy part of it is good enough. I'm very much for cystectomy part than doing the laser part, sir. I have nothing against laser. Laser is something which are very, very new, which are good. You don't go into a lot of depth into that. You don't. You only destroy the cystic wall. But but whatever little that I've learned from from abroad, whatever I've heard, I've seen the literature part of it. The so much of hype that has been created with lasers are actually it's actually not reflected on the ground or on the patient, sir. There isn't much of an additional advantage over there. I believe it must be some sort of it may be helpful to
കഴിഞ്ഞിട്ട് പോകും വെച്ച് വിട്ട നാളെ രാവിലെ വയറ് കഴുകുക അല്ലേ
take
നാളെ
a lot of time for us to accept it. But till even into AGL, you go to X-ray guidelines, you go to the ESG guidelines. All the guidelines actually are very much even in favor of an ovarian cystectomy part of it, sir. So this is my take on it.
Have you come across something like isolated fallopian tube torsion?
Sir, I do have a video, sir. I do have a video of isolated tubal torsion, sir. Single tubal. Very, very rare. Very, very rare. I think there's one more from Dr. George. George, here? Dr. George, are you here? Yeah, I have seen one video of pulsar also, an isolated tubal torsion. Though very, very rare, so it's actually very, very rare, as I had shown. It's a very rare one, sir.
Sometimes happen to see in adolescent girls, isn't it?
Yes, sir. Yes, sir.
Not common. because see, there is some after the onset of menarche, there can be some different means exacerbative response to the tubal motility by from the hormones. So this can result in isolated tubal torsions. So that's why it is said
Yes,
to
sir.
be more common in adolescents.
Sir.
Now,
One
just
good
I
thing
had
I would like.
only some 2
There
or
is a
3
request
occasions
from the
past.
audience.
Madam.
Subhash,
Oh, madam.
there is a request where can you show the Pexi video once more?
Right, ma'am. I'm showing it, ma'am.
Yeah. And meanwhile, I have a doubt.
Madam.
What is your take on ultrasound guided tubal aspiration? I mean, so cyst aspiration, especially in endometriotic cyst.
Unless and until your idea is to help you out for home pickup during this, ma'am. Otherwise, I'm not much in favor of it. It will just recollect in some time. If you're not able to reach the hilum, or you're not able to get the ovum, fine. Only for that reason, because it will just come back in about few days time. Now,
Yeah.
coming to the picture, you can see here we have taken a stitch through the ovary and through the round ligament, and actually, so I'm really sorry, through the the ovarian ligament, and then you actually fix it. Here again, you can see you're taking a fix through the infundibulum pelvic and again taken across to the surface of the ovary. You cannot go very superficial because it will actually get sloughed out, but you have to go slightly deeper to that. Okay, you're actually doing it fixing because you already had once bitten, twice. I keep saying once bitten, twice shy. Now, this is the case which you have. You can see the tube again over here on the left side. I'll just come back over here. This is what I was saying. When you see a tube like this, you have a tendency to remove or not. Don't do that. Do not worry. It will just come back to normalcy in some time. Maybe, as I keep saying, 6 weeks. You do a scan, it will think come. Again on the right side, again, you can see here, take a couple of stitches. But don't go very deep in this area because you have the vessels which are coming below and that will cause a torrential bleeding over here. Okay, this is something which we normally do. Okay.
What about infundibular pelvic? Won't it bleed?
No, ma'am, I've just taken through superficial. You can see the vessels, ma'am. In the infundibular pelvic, ma'am, you have both the artery and the vein. It's actually very superficial. You can see over here. It's from a very, very superficial one. It's from very, very superficial because you're shortening the infundibular pelvic ligament, ma'am. As I said, if I can go back to the previous one, again, I can see this hot dog and bun. Okay, posterior ovarian fossa, you can actually placate the posterior ovarian fossa. Again, the next one, you can placate the ovarian ligament, and of course, bilateral ovaripexy. Anything of this can be done, but this is what we normally do. Is more of this is again the same thing. Again, over here, as I showed you, is this. Okay, you take a stitch from here, you take a stitch from below. Okay, again, there will be when you take the through this from below the tube, it would bleed. It would bleed. So don't worry about it. It would bleed for some time. No, there will be some moment of bleeding, but it will stop in some time. Okay, you can do over this. You can see over. And then through this, you can fix all the three layers. You know, you can fix all the three layers, the round, and also the over and across. Just fix it across, and that's how it would look like. Okay, maybe three stitches. You can use a Vicryl. You don't have to use a lifelong, something like a silk, a merce silk or proline, because all your ideas, you cause a chronic inflammation. You just cause a chronic inflammation for some time, and this chronic inflammation is good enough, for it to be actually holding it over for a longer time. I'm
Thank-
yes, ma'am.
Yeah, that's what.
I'm
Thank
very
you
happy,
again
ma'am.
for
I'm
showing
very,
it
very
again. Yeah.
I, I am very, very happy to see, ma'am, in the for the Monads talk, I'm very happy to see, very senior, probably I can see Nishi Roshni, madam here, Ramesh sir is also over here, then we have Dr. Rachel from LFP. I'm very, very happy to see Dr. Shaini Varghese also all the way from Baptist. Hi, ma'am. Jacob sir is also, Hema madam is here. Dr. Shaini,
Hi, hi,
yeah, it's a pleasure to see you, ma'am. Pleasure
hi,
to see you, ma'am.
hi.
Hi. No, she's the HOD of Baptist Hospital. Again, and a lot
Yeah,
of other
Agni madam
seniors
is
are
there.
over here.
Dr. Rajni Agarwal is there.
Rajni Agarwal, ma'am. It's so nice to see, ma'am. And don't expect, again, we also have our KFOG President, Dr. Hema Warrior, madam. We have Dr. Chandrasekhar Naik, sir, is also over here. It's very nice, ma'am. Nice to see a lot of seniors also over here. Sorry if I've missed Dr. Ansi, the secretary of Kollam is also over here. It's nice, ma'am. It's nice to see a lot of seniors.
Hello, Subhash. Hello.
Hi, ma'am. Hi, ma'am. Hi, ma'am.
Hello. Yeah, very
Jackson,
nice
sir.
presentation.
Jackson, sir, are you the secretary of Perinalmanda, sir, incoming? സാർ ഒരു കുടുക്കിലായി പോയി. Right.
Dr. Reshma is the new secretary.
Acha,
Subhash.
Dr. Reshma, madam. Okay, ma'am. Okay. Congrats, ma'am. Okay, ma'am. I think if there are no
Okay.
questions,
So,
we'll go to the
yeah.
big boss.
Okay. Thank you so much, Subhash.
Okay, ma'am.
Okay.
Thanks a lot, ma'am. Thanks a lot, ma'am.
Cam, are you there? Hello? Yeah, he's very much there. So now after the secretary, we have the president with us. So I don't have to elaborate on Dr. Kunimoidin's credentials. He's our KFOG president for this year, 2023-24 and 24-25. And he's actually the founder president of Perinthalmanna OG Society. He's a master brain behind this society. And we all know like he's now like Tata Birla, he has become, he has combined with his ARMC with the Birla. Now he's a Tata Birla type of person also. So apart from all that, he's a very genuine individual and a very helpful person to all of us here in Kerala and outside state also. For all who have had contact with him will know him for that genuineness and his sincerity. So over to
That's
your
enough.
presentation. Over to your presentation, came on TLH. Thank
Yeah.
you.
Thank you, Dr. Thus, the President, Perinthalmanna Anji Society, Dr. Reshma, the Secretary, Perinthalmanna Society, all the members from the society and all across the Kerala and outside. So after having an elaborate and electrifying presentation by George and Subhash, we'll just peep into something called total laparoscopic hysterectomy. Now, there are a lot of momentum which is happening on various types of hysterectomies, vaginal hysterectomy, abdominal hysterectomy, and laparoscopic hysterectomy. So I'm just more versed with laparoscopic hysterectomies. So it is more than the equal to the indications for hysterectomy. It is the how expertise you are in the mode of hysterectomy that is actually be the most important part in deciding the service with regard to the hysterectomy to the patient. And also now we have the hysterectomy audit by the government of Kerala, where we all have to submit the monthly audits to them. So ideally, the hysterectomy for a woman, it should be the last thing which we have to resort, unless all other medical treatments are failed, conservative treatments are failed with regard to the benign disorders. Whereas in the suspicious of malignancy or any other things, it is always an option to consider. So we'll just briefly look into what all things are the important steps, what are the practical tips in the difficult cases, and so on. So to begin with, I'll be showing a case of adenomyosis and endometriosis, where always there is a chance for all of us to land up in troubles. But if you take proper care and if you anticipate the things, the chance of getting into the troubles will be less. Dr. Lola, can you mute?
Others, please mute. I request others to please mute. Lola, madam, is that? Yeah. Thank you,
Yeah.
ma'am.
So basically, see, there are some things like towards a successful TLH. Successful TLH or total laparoscopy hysterectomy, that doesn't mean that you are completing the procedure in laparoscopically. A successful means you are completing the procedure without much complications, without any complications rather, and to make the patient safe. So that is more important. We should not have any hesitation in our mind. In any difficult scenarios, you should be able to mentally prepare to convert the laparoscopy to a laparotomy in any other situations. And here, these are the things which you need, the list of equipments you need to have. All these things, there are some of the things which are fancy, but I tell you that you don't require a lot of fancy equipments like the harmonic or anything like that, or any costly manipulators or anything like that. You can do a total laparoscopic hysterectomy with very simple instruments which are not very costly and available. The main thing is that you should have a very good bipolar instrument, as well as you have a very good optic systems, cameras and optics, etc. And preparation and positioning the patient, it's better to get admitted some 4 hours or on the previous night, or if it is a day case surgery, you can admit it that day morning itself, advise the patient. And always, it is always better to have a pre-anesthesia checkup. So the anesthetists are the best person to judge the patient that whether the anesthesia, that patient is particularly fit for anesthesia. There is a tendency that to overcome them just to show them before the surgery and so on. And have the equipments all sterile, either ETO or sterilized by any other way. And you have to have a previous checkup because all these are technology-driven equipment. So you have to be very careful about the working status even on a daily basis. And why I mentioned it is insertion of a uterine manipulator. There are a lot of studies happen. I could see whether a manipulator is required for a laparoscopic hysterectomy at all. So like a uterine sound or dilator or some manipulator you are putting into the uterus, actually you are splinting the uterus. Actually, a uterus is such a nice mobile organ, or you can turn the uterus or push the uterus, pull the uterus any direction. Whereas as soon as you put the manipulator in it, actually you are splinting the uterus. You have to be very careful about it, and you have to think about that limitation when you are putting the manipulate. That's what I mentioned. And abdominal entry and trocar placement, you already heard an entire talk on that. So depending on the size of the uterus, previous surgeries, you can decide on the primary trocar placement. And always be careful about the basic principle of the inclination of a trocar entry in the obese as well as the thin patient and the additions. And most common surgery which we come across in this situation is the previous cesarean. So always in a fan, the incision on the abdomen may be a fan and steel, but remember most of the time the peritoneum will be cut into vertically, and the additions also will be there in the vertical according to that peritoneal incision. And the second thing which we have to be important, there can be a lot of cases, you can see umbilical hernias. So that is where one situation your pot can directly enter into this herniated fat. Most often it will be the omentum. So accordingly, you have to think about where to put the primary port, about the umbilicus, Palmer's point, on Newton's point, Jane's point, or something like that. So total laparoscopy hysterectomy without uterine manipulator, that's what actually I mentioned. A TLH without the use of manipulator is feasible and safe procedure. Basically, you have to be well trained and experienced about it. So here I'm just showing a case of the total laparoscopy hysterectomy in a case of severe endometriosis with adenomyosis. This patient actually came from abroad. She presented with severe dysmenorrhea, severe pelvic pain, and the menorrhagia. And all the conservative measures have failed in this patient, including a double marina has been kept, but it was not successful. So basically, in these situations, you have to think about adhesiolysis. See, you need not think about doing adhesiolysis down towards the cervix or the entire deep end of the pelvic pouch of Douglas. Rather, you have to do the preliminary adhesiolysis to start with. Then, when you slowly progress as the steps you go down, the uterus will get mobilized. For that, just to start with a minimal adhesiolysis, and the adnexa should be free from adhesions. So then only you will be able to remove the adhesions. So why I selected a case of adenomyosis and endometriosis, because you might have seen a lot of simple cases of total laparoscopy hysterectomy in many of the workshops and the YouTube videos. And also I thought of putting a difficult case here. So at the same time, I'll tell you how a normal thing will look like. So once when you start done with minimal adhesiolysis, then you can go with the round ligament. So the most important practical point when you are coagulating and cutting the round ligament, you have to be keep little bit away from the uterine surface, should not be very close to the uterus. So catch hold of a good length of the round ligament, coagulate, and then cut it. Don't think that you can just cut it and go away like that, that we are doing the coagulation on the left side now. So as soon as you cut the round ligament, uterus will become a little bit more mobile and you can pull it with the myoma screw or something like that. Here, I just would like to tell you a tip where whenever you are trying to put a myoma screw into the uterus, always try to inject vasopressin into the subserosal plane so that that point of putting the myoma screw, because in a large uterus, you may have to put myoma screw in different places. So before when you are putting it, the better inject the vasopressin so that bleeding from that point can be reduced. And here again, the adduceralysis, after cutting the round ligament, I'm doing a little bit more adduceralysis. Now, say in severe addition cases, you can remove the adnexa and keep it separate if it is pathological. And if it is not pathological, you need not remove it. Generally, I don't remove the ovaries unless otherwise the patient is postmenopausal or anything. So rather, but I make sure that the fallopian tubes will be removed if the ovaries are keeping back. So here, see, the adnexa, specifically the ovaries, should be freed from the ovarian fossa. Then only you are supposed to remove it. If at all, if it is pathological, it has to be free from the ovarian fossa, because that is one area where the ureters can be injured, because direct injury with the scissors or something you may be able to recognize, but the thermal injuries, it will be late, the manifestations will be late onset, and you will realize it only in the next postoperative day or so on. So just keep coagulating the ovaries as close to the uterus or the ovaries, not going to the lateral pelvic wall. And in this situation, I would recommend not to hesitate to go into the retroperitoneal area if there are a lot of adhesions. You can enter after cutting the round ligament. You can easily enter into the retroperitoneal area so that you can see the ureter beautifully and can remove the ovaries easily. So the next step is going to dissect the UV fold. So keeping the bladder away, keeping the adhesions away, and to have a good plane, it is always important. So need not cut at a single stretch. You just allow the pneumoperitoneum to enter into the uterovesical fold. You can easily lift the uterovesical peritoneum and cut it. At the same time, you have to pull the uterus upwards so that you can see a good uterovesical fold of peritoneum, which it will be easy to cut. And always respect the fat tissue, because fat belongs to the bladder. So always keep, remember that. And just by small steps, you just keep continuing to cut. And always at this point, when you cut on the both extremes, usually on the right extreme or the opposite end of your ipsilateral port, so you have to be very careful, because the external iliac vessels will be there, the veins will be there. So to be careful while using the cautery and complete the dissection of the uterovesical peritoneum. So here I just would like to show another case at this point so that I'll not miss it. Previous cesarean cases. Previous cesarean.
NED 189, huh? But NED buildings in a view usually right, huh?
Please mute.
So the uterovesical fold of peritoneum, usually this point will be very much adherent to the uterus or any fibroids or anything. You can see here the uterovesical fold of peritoneum or the bladder is adherent to these fibroids which are there on the uterus. So basically it is a pedungulated fibroid, but it is very much adherent to the bladder surface. So that is the thing which you can see. You can see it is adherent to the abdominal wall. So here again, we are starting with the cutting the right adnexa. So here actually we say when cutting the ovary, it is hugging the ovary. Keep the incision, cutting the ovarian ligament close to the ovary, not close to the uterus. Here you can see the peritoneum is adherent, and you can see the bladder here. And see, make a plane, slowly cut the adhesive peritoneum onto the fibroid. Actually, this is a large fibroid, and the uterus is a little bit on the below. Here I am using the instrument called Thunderbit. Thunderbit is basically a bipolar instrument. So it will beautifully, it is very easy to use and cut with the Thunderbit instruments. And here again, the additions on the lateral side. So just make sure that, let's see, you are getting into the right plane. Don't go somewhere near into the this adipose tissue and get into the bladder. So slowly separate these areas. Now you can see the uterus here and the bladder here. Actually, the bladder is adherent to the fibroid here. Again, this half of the bladder is embedded into here. So slowly cut it. And here also, rather than cutting the bladder pillar, just coagulate a bit and cut it, because that is the area it can bleed a lot, and that can obscure the entire field, and it will be very difficult to catch the bleeding point, because you will be keep on coagulating the thing. Again, on the right side, you can see the adhesions, and lift the adhesions with a ball forceps or a traumatic forceps, and slowly you can easily cut it. So make sure always you are cutting close to the uterus or the fibroids which are there at present. So always a previous cesarean with any other pathology like endometriosis or multiple fibroids, it's always a risk that you may see the Foley's catheter which have been put into the bladder through once when you make an opening into the bladder. So here again, you can see a strong adhesive band, lift it and check it, and you can cut it easily with these Thunderbait instruments, and you can easily find a plane, and so that it will not you will not inadvertently enter the bladder areas. There is some bleeding which can be coagulated. Again, this is a strong this is an adhesive band that also again cut. Once it is cut, you can see that you can see the bladder here. Bladder here you can see here, and it will easily see that is a bladder in between. You can just push towards you and see, and that is the round ligament which is which has to be cut again, but round ligament plus the addition, because this patient had already had the 3 previous cesarean sections. That is why this much additions. Even if it is a single cesarean section, you can see very often during cesarean, we the gynecologists push the bladder down with a mop and so on. So these are the situations. Always sharper dissection will not create that much additions, whereas a blunt dissection by pushing with mop, then coagulating, pushing with mop, these are the things which cause a lot of deadly additions, and it will be problematic. So now you are seeing it, and now I'm just removing that fibroid from that adhesive that it is there in that adhesions. Now you can see the uterus very clearly, the bladder down. Now continuing with the remaining part of the UV fold. Earlier we have dissected the adhesions. Now the UV fold is being dissected on the left lateral side, and here you can see the bladder, and the other side ovaries there. And some places if it is bladder pillar, you see some vessels there, you can coagulate and cut it. So you can, when coagulate, if you are sure that it is only the bladder pillar or any other tissues like that, you can easily coagulate and cut it, nothing will happen. And it is on the other side, the bladder pillar is being coagulated, and it will be cut like that. And now you can see the clear surface. Now you can see the clear area where it is. Now the vaginal manipulator is there. I generally don't use the Clermont-Ferrand or any other manipulators. Generally use a very cost-effective vaginal tubes of various sizes. So depending on the vaginal size we use. And now, and one more thing, I make a nick or make a small opening in the anterior vaginal wall. Anterior colpotomy will be done in the beginning itself, so that I will not overshoot the dissection on the McEnroe ligaments. I'll have a target that I have to cut towards that colpotomy wound, so that the dissection or the cutting on the left lateral side or the right lateral side will not inadvertently, it will not go much below. So there are different ways you can do it. You need not even cut it. You can do it straight away without opening the anterior vaginal wall. So the one disadvantage of opening is that your assistant should be very perfect. Otherwise, your pneumoperitoneum will not be stable. So here it is, I'm just coming back to that previous case where we were discussing about that severe endometriosis and adenomyosis. Here again, you can see. So here, this is one idea where you can push the bladder down with your blunt forceps so that you know the anterior vaginal wall. Again, there will be vaginal fascia that can be cut, like an intrafacial hysterectomy where you do you can do while in open surgeries. So here again it is intrafacial, so you are cutting it and make a nick in the beginning in the anterior vaginal wall. So here you can see we are cutting the uterine arteries on both sides. So if you are not very clear about the pedicle, you have to always push your vaginal tube towards that side. Generally, what we do, we'll push it to the opposite side. Here, you push it to that side and pull and push the uterus to the opposite side, so that you can easily coagulate the uterine vessels. And here, one more thing which I would like to mention, that this vaginal tube, once you put the vaginal tube and push it upwards, if there are not much adhesions, the ureter also will stay away, and it will be a good protective thing, so that you can easily see it. You can see the vessels are being coagulated, desiccated, and being cut, and it is being taken care at that point. And here, so we have reached, so that is the one point we are isolated the uterine pedicle. Now it is being coagulated and cut with the thunderbit. So it is, and thunderbit is actually, it's a real versatile equipment to coagulate and cut at the same time. And it's on the other side, you can see. So we are reaching the, see, now you can see we are reaching the vaginal wall ankle on that side. So here I just want to show you the how clear a uterine artery pedicle if there are no adhesions. This is the same case where we did that anterior bladder dissection in a case of previous 3 cesarean. Once after the bladder dissection is done and the anterior vaginal anterior fornix is open, now everything is very much clear in this case. You can see the broad ligament, then that can be coagulated and cut. Here, actually, you can straight away coagulate and cut the uterine arteries. And see, you can see very clearly, you can see. And whenever you are going ahead with coagulation and cutting, you can even isolate the posterior leaf of the peritoneum, so that in a vascular pedicle, make sure that you are coagulating only that vascular pedicle after skeletonization, because you can even do in a normal size uterus, you need not even skeletonize, but in where the arteries can be bigger diameter in the large uterus or adhesions and all, here you can skeletonize and then cut it. So you cut the posterior broad ligament, cut the anterior ligament, skeletonize it, and easily you can cut it. And at the same time, you can just observe on the posterior side. Then this on the left lateral side, this Meccan rods can be taken care. And here I would like to mention a few things on the posterior aspect. So this is the posterior aspect, round ligament insertion on these sides. Also, if you make a cut above the insertion of the round ligament, the advantage is that you need not detach the round ligament fully from the vagina. So round ligament will be still connected to the vaginal vault. So the chance of, in these cases, because there is no descent, no prolapse, nothing, so there is no need to suspend the vault or anything. So the uterosacral ligament is always preserved to the vaginal vault. It is not a supracervical hysterectomy or anything. You can still isolate the cervix from this one. And now you are seeing the posterior rim of the vaginal tube. So now that side is getting completed. So here again, the Meccan-Rods ligament in that previous case of severe endometriosis, you may wonder, see, as and when we are progressing with the hysterectomy and dissection, uterus is getting slowly released from the posterior adhesions as well. And finally, you can remove the uterus through the vagina, doing in pieces. Sometimes in very large uterus, like 20 weeks or 24 weeks uterus, sometimes we may have to do partial morcellation from above before facilitating to take it out through the vagina. And make sure that after the see, I'm of the there are people, some people who do not close the vaginal vault. Somehow I'm not comfortable with that one. I always close the vagina with the simple vicryl suture. I never use this barbed suture or anything for this one. I am quite comfortable in putting the knots. So so the expense for the suture also less. And it will be just like a continuous suture, like what you do in open abdominal hysterectomy, and make sure that the angles are being taken properly, so that the secondary hemorrhage possibilities are very less. So then you complete the knotting, and so that then do a very good wash and see it. And these sort of cases, so if you have any, see, I don't do cystoscopies generally, but only in such cases, some places where we observe. So I couldn't trace the cystoscopy in this picture from the recordings, but this case we had done cystoscopy with the hysteroscope. You can do it very easily to see the ureteric peristalsis and the urine coming into the bladder. So that's what actually we have to do. And post-operatively, see, generally, sometimes patients prefer to get discharged on the same day if the early morning hysterectomies are done. But some patients, maybe almost half of the patients, they want to stay back in the hospital for the purpose of insurance. And also, they'll be mentally comfortable in staying back. But maximum, we keep them overnight and discharge them on the next day, and give analgesics, good analgesics to be given, mainly the paracetamol IV infusion can be given, prophylactic antibiotics, no full course antibiotics is not required. And the catheterization is actually, the continuous catheterization also is not required unless otherwise you suspect some too much of bladder dissection. Ambulation, early ambulation is the key for patients' early recovery. If it is because in the lithotomy, modified lithotomy position, there can be chance of deep vein thrombosis. And peculiarly, most of these patients, specifically menorrhagia patients and adenomyosis patients, they might have taken a lot of hormones earlier. That again increases the risk of DVT. We regularly use DVT pump and heparin only in indicated cases, and discharge the patient on the next day maximum, sometimes on the same day as well. So some practical tips I would like to highlight: if the uterus is large and requires manipulation with a tenaculum, as I mentioned earlier, dilute vasopressin subseriously prior to applying the traction to the uterus with the Myoma screw. If access to the uterine vessels is difficult, take the uterine vessels up high lightly, so the ascending uterine artery can be coagulated and dissected, like what we had done in that severe adhesion patients. Then slowly secure the blood supply to the upper uterus, and then gradually work down, keeping close to the uterine surface, staying medially to the vessels. Maintain exposure at all times. Do not dig yourself into a hole. Always be ready to deal with a sudden onset of bleeding. So your vision should be clear. And sometimes some arteries, some arterial bleedings that can come onto your scope, immediately clean it and see it again. The combination of a prior cesarean delivery and a large uterus is a setup for bladder injury. Stay high on the vesicouterine peritoneum. If there is any difficulty to go lateral, lateral approach is the lateral window approach is the most acceptable one. But in some cases that also may be difficult in previous 2-3 cesarean sections. Then you start from the most proximal end of the adhesions and slowly cut below. And here, due to over enthusiasm or over care, you may dissect onto the uterine tissue. That again will create problems and severe bleeding can happen. And try to get the proper plane. In such cases, you can keep them the vaginal manipulator, means vaginal tube, in place. So that will tell you where the vagina is or to what extent you have to dissect it. Otherwise, unknowingly, you may dissect more extensively. And respect any fat you see. Fat in the anterior one that belongs to the bladder, fat in the posterior one beyond the denominal fascia that that belongs to the rectum. And watch out for air in the Foley's balloon. And in severely distorted anatomy, consider entering the retroperitoneum sooner than later. So it is always better to enter as early as possible. And the most easiest starting point is usually the round ligament. So surgical morbidity of total laparoscopic hysterectomy for benign diseases, these are the predictors of major postoperative complications, can occur in about 7%, and huge effort should be made to reduce the intraoperative complications. So the complication that starts right in the beginning itself, your port of entry. So you have to have a clear-cut idea about the size of the uterus, previous surgeries, additions. So as once you are safely inside the peritoneal cavity, relax a bit and slowly doing it, and slowly you can complete it. Then the next point of the complication can occur if it is a severe additions like I showed here. So there you have to slowly.
Please mute, madam. Please mute your phone.
So you have to release it slowly, need not aggressively release till the deepest point in the beginning itself. As and when your hysterectomy is progressing, you can release slowly, and nothing to worry. Even if you are taking more time, you will be able to complete it. That doesn't mean that you should do a hysterectomy by spending 5-6 hours and all. And endometriosis always increases the risk of major postoperative events. And you should have a very good anesthetist, very good COT monitoring system in your anesthesia machine. So all this will help you to have a major peace of mind. So with that, thank you for the patient.
Thank you, Cam. Thank you for that beautiful videos. You really showed us all the planes, and I must say the blood loss was minimal. Couldn't find any major bleeding points at all. So total bloodless surgery it was, in
Yeah,
spite of the additions. Yeah.
Yeah, if you use vasopressin judiciously, so sometimes these additions, if you not only in endometriosis surgery, here when you do hysterectomy for endometriosis, if you inject vasopressin to the subserosal plane, it will spread into the ovarian fossa and the pouch of Douglas, and almost the additional lysis will be almost bloodless.
Okay. There is one question, whether injecting lignocaine to the vault will reduce the pain, post-operative pain.
So I don't have any experience in injecting lignocaine. Why do you want to inject so many unnecessary things there? Rather the port, the laparoscopy port, that also I have seen people injecting lignocaine after the surgery. That doesn't make any effect. Actually, preemptive analgesia, where before you stimulate the nerve endings, inject lignocaine, then put the incision. So that is the actual point. You just leave alone the vagina free.
Now, if I can add to the lignocaine, now we can add to lignocaine. The fact again remains is the reason for the pain is amount of bipolar or monopolar, the charging that you cause. The larger the amount of charring, the more the amount of pain that you're going to have. So basically, when you open, the best thing for opening the vault, of course, if an harmonic, fine, well and good. Otherwise, it's monopolar actually, which is better because it's least of the damage. Hence, basically, it's the way you open the vault using the energy source, and the way you close it across also matters. So pain is basically due to the way you have opened based on your energy source. The more
Thank you.
the
Thank you.
Yeah, and also the things like hypertension. That is one thing we have to take care of very much, because the patient should have the BP control before you taking up for surgery. Because as such, the intra-abdominal pressure, increase in the intra-abdominal pressure can raise the blood pressure. So post-operatively also, if the BP is not controlled, there can be, because we are not suturing, there can be a few oozing, clots formations and pain and so on, isn't it? Some small things which may be.
Yeah, and there are so many practical tips also that you shared, like how to handle each pedicle and how to prevent the injuries to the ureters and all that. Thank you for all those practical tips, and it was very excellent presentation and even more excellent videos. And one more question is coming up.
one
What
more
is
thing.
the best way to close the vault to have minimal pain? Another question in the chat box. Yeah.
Again,
Yeah, I think Subhash can answer that one.
the point which Dr. Kunjamudin sir told about, when you have an endometriosis and you have a lot of sigmoid adhesions, our tendency when we operate is go and dissect out till the bowel, not even below that. Go and go to the period and everything. But unfortunately, please remember that when you push up the uterus from below, you put up your vaginal tube or something from below, you don't have to really go down. I always tell this. You dissect more anteriorly, you dissect less posteriorly. Because the moment your uterosacral just come up, because just need to close your uterosacral. You don't have to go dissect out the bladder, dissect out dissect out the bowel, the rectovaginal fascia. You don't have to go so deep down. The more you go deep down, the more amount of complications that you can occur. Your idea is what I'm not saying you don't do a good dissection. I'm saying be more practical in your approach, be more pragmatic in your approach. That's what we normally have to do. So there's a very good point. There is no place for heroics in surgeries. There is no place for heroics. There is no place for all these. I've done this, I've done that. At the end of the day, the life of the patient, the morbidity of the patient is more important. Again,
And closing the vault, just close it simply, just like a purse. You don't take too many bites on the Meccan rods and uterosacrals. That can create pain. Am I right?
yeah. May I really inquire with the person who's asking the person who's asking what is that you want us to tell us? What is exactly your doubt? Whether you have pain in the vault, again you have pain in the vault, again you have closure techniques. Now what exactly do you want us to tell? Because I am somebody who is using barb sutures for the last 14 years. From 2010, I'm using barb sutures day in and day out on all my vault. People will find fault with me. I'm wasting a lot of I'm wasting a lot of money on.
Please mute. Please mute. Yeah.
But when you put a barb, the advantage is you have uniform tension, you have uniform, then the chance of your rupture, chance of your postoperative bleeding is all less. But that doesn't mean that you use your barb for every patient. No. You can use a simple vicryl, put two stitches on two edges, leave some amount of gap in the middle so that if there's some fluid to come out, it can come out. There's nothing like hard and fast that you can even close it from below. You need not even close it from above. You can also close it from below. So basically the closure technique is all what is left to your comfort with. But anything can be done as long as you're comfortable with it. What is your comfort is more important. But if you're looking for some RCT, if you're looking for some RCT, which says this is better than that, there is no such RCTs. There is no such RCTs.
Anything about leaving some part of the vault open?
Ma'am,
See,
seniors,
I don't leave it like that because I have seen many people leave the vault open and they'll be leaking of the fluid, peritoneal fluid, and so on. Patient will have menace for so many months. So better we close it, isn't it?
Like Dr. Subhash mentioned, can be closed from below or barb suture as well. And
Yeah.
unlike the old technique, I think it's always better to close it properly rather than leave any opening.
Exactly.
Sort of confusion.
And it depends upon our convenience. See, you need not even see for laparoscopic hysterectomy, you don't even know to do suturing, endoscopic suturing. You can suture it very well from below. Unlike myomectomy, you should know suturing there. Here, you can even manage without knowing suturing.
But the only advice I'll give you when you're suturing from below is please take the uterosacrus. Because initial phase of your hysterectomy, when the laparoscopy came down about 20 years back, a lot of disrepute, or 30 years back, a lot of disrepute was there, a lot of wall prolapses were coming.
Yeah.
The reason for the wall prolapses was because you're not taking the uterosacrus very much, very properly. When you're doing it from below, you have to take the uterosacral, you have to incorporate the uterosacrus in your stitches if you're closing it from below. From above, if you're opening the vault from above, please understand that you have to maintain the pericervical ring. You maintain the pericervical ring, your chance of vault prolapse is almost next to him. But what we
uterosacral will still support it.
you just destroy the whole of the vault and then you take suturing only on the vagina. The vagina is a muscular organ that doesn't give you any sort of strength. The vagina will not give you any. It is just an approximation. That's it. So always maintain the pericervical ring from above. If you're suturing from below, take the uterosacral into it. But don't be over enthusiastic and take a deeper bite and have the leak, coming down in about 8th or 10th day. You have some fluid or urine coming down. Don't be over enthusiastic also. Kunjamati sir, you were saying something. I was.
No, it is same thing. See, mainly that pericervical ring that in that, you can shave the Meccan rods, you can shave the uterosacrals from the uterine tissue so that it will be still connected to the vaginal ring properly. So that doesn't mean that you are doing some supracervical, but still. it will maintain that all ligament connection to the vagina. And angle should be taken properly. Whether you are suturing from below or above, the vaginal angles, vault angles should be dealt properly.
Excellent practical presentations, all three of you. George Paul, Subhash, and Kunyamandi. Congratulations.
Thank you, Emma madam.
ma'am. Thank you.
So, thank you all. Thank you, George, Subhash, and KM for the wonderful presentation and sharing your beautiful videos. A great tip for all who do laparoscopy and great inspiration also. So I think we can close the discussion now. If there are no more questions, I think we'll call it a day.
വിശക്കുന്നു madam.
അതെ അതെ അത് ശരിയാണ്. So thank you. Thank you, KM. Thank you, Subhash.
Thank you, ma'am. Thanks.